James, thank you for agreeing to talk at our KSS Respiratory Collaborative in October. I know you're a consultant in North Bristol with your day job, but tell me about your national role.
Yeah, I'm really excited about talking to you guys. I've got two national roles I think are relevant. I lead the asthma component of the National Asthma and COPD audit, and I'm absolutely passionate about improving care for asthma patients. And I've also been working with colleagues in the severe asthma field, looking at how we can work together to improve standards of severe asthma care. And that's a bit of work led by NHS Improving Value and the National CRG for Respiratory Medicine led by Andy Menzies-Gown.
So big roles there. Now in KSS, we've been running a COPD discharge bundle program for some years. Are you a believer in bundles?
Well, I'm certainly a believer in KSS. I've been so impressed by the work you've done in your area and the work done in the Northwest by Aqua. I think it's absolutely class leading. Am I a leader in bundles? Absolutely. But as a believer, I'm also aware of the potential pitfalls and the challenges of implementing them. The easy bit, if you like, is writing the bundle. The work I did as part of the COPD trial bundles that I did through Bristol University showed that if you implement a bundle, patients are much more likely to get all the aspects of best care. But unless you're doing it at scale, unless you are implementing bundles reliably in the majority of your patients, you probably won't achieve the improved outcomes you can. So it really is a work in progress. It's something you have to keep working away at.
Yeah, that's what it feels like, I have to say, keeping at it. And I hear there might be some focus on asthma nationally. Are you able to say a little bit about that?
Yes, absolutely. We published the first report of the sort of first 8 months of data from the National Asthma Audit, unfortunately, just at the height of COVID. So I'm not sure that everybody will have had a chance to give it the attention it deserves. But it really shows the value of the care that everyone involved in respiratory medicine provides. And it also, for me, acts as a bit of a call for action. There are things that we could do better. So we're going to be trying to encapsulate the messages from the audit in a number of areas. So first of all, we're very keen that people look at the first hour of care so that we make sure that patients arriving in hospital with an asthma attack get the same attention that other unwell patients get. And the audit's thrown up a number of areas where we could certainly do better. And also the audit's very much shown the benefit from the multidisciplinary respiratory team, because if you're seen by a nurse, a physio, a doctor, someone who's trained in asthma care, you are 25 times more likely to have your smoking addressed. You're more likely to go home with a personal asthma action plan. You're more likely to have your inhaler technique checked. And really, it's not acceptable for any of our patients to go home without those very basic aspects of care addressed. And if the care is led by someone from the respiratory team, it's more likely to happen. So I think it's a challenge for us to work out how to do that. How do we deliver a specialist standard of care to everybody? And that doesn't necessarily mean it always has to be delivered by a specialist, but I think it probably needs to be led by a member of the specialist team.
Okay, so we'll look forward to hearing more about that and maybe having a discussion about how we improve asthma care in October. Thanks, James.
I'll look forward to it.